Hello everyone and welcome back to Pharmacology with Dr. Sokolow. So we are still in the chapter of the anticoagulant, antiplatelet and thrombolytic drugs. And today, this particular module, I'm talk about the oral anticoagulant. So in last module I discussed the parenteral anticoagulant, and in this one it's focused only on the oral anticoagulant. So then again, when you study, make sure that you compare and contrast the mechanism of action of the parenteral anticoagulant and the oral medication, and also what are their indication. So the first oral anticoagulant is Warfarin, and it's the oldest one, and for a very long time this was the only oral anticoagulant available. Warfarin was actually discovered from the rat poisoning. It's, for its anticoagulant properties. I guess that's how it kills rats. But it was then, tested in humans at, lower dose, and found very effective for the purpose of, preventing clot formation. So I don't know if this drug would be going through the approval of the FDA if it has to go nowadays, but at that time it got the approval, and thankfully, because it was the only oral anticoagulant and saved many lives despite the high side effect profile. So how does this drug work? It's actually a vitamin K antagonist. So if you remember from the previous module, I explained that anticoagulant can work in two different ways. They can either block the activity of the coagulation factor, or they can inhibit their synthesis. So Warfarin inhibit by blocking the synthesis of the vitamin K dependent clotting factors, such as prothrombin 2, which is prothrombin or factor 2, factor 7, 9, and 10. And all these factors are vitamin K dependent, which means they need vitamin K for their synthesis. So as you can see here, these are all those factors in green that requires vitamin K for their synthesis. Therefore, Warfarin, which is a vitamin K antagonist, is going to prevent the synthesis of all those vitamin K dependent factors, and ultimately will block the formation of fibrin, and that fibrin polymerization and fibrin clot. It has a very long half-life, so you see 37 hours. Again, this brings you back to your principal factors. What does it mean when you have a long half-life? It means you would require to give a loading dose, or patient can be on a parenteral anticoagulant such as Lovenox, the enoxaparin, one of the fractionated heparin, and then they have to be converted slowly to the oral anticoagulant because the effect of warfarin takes several days. Clinical use, so oral anticoagulant, prevention of deep thrombus, deep venous thrombosis, prevention of systemic arterial embolism, prevention of MI and stroke. For patient who has a prosthetic heart valve, in that area around the valve, you can have some coagulation and clotting around the valve. So this is something that is used in those patients to prevent the coagulation around the valves. And then prevention of AFib. You'll have a lecture specifically on AFib, and so you will see this medication again for that purpose. So warfarin, as I said, is not a drug that is devoid of side effects, since it was used in rat poisoning, and it's a drug that needs close monitoring. So that's one of the disadvantage of this medication. You probably heard about the Coumadin clinic, where the patient has to go sometime 3 times a week, sometime more if they are starting the medication, to titrate their level of Coumadin, because the major risk of using that medication is bleeding. The good thing, this can be reversed with vitamin K, because as I mentioned, the mechanism of action of Warfarin, it's a vitamin K antagonist. So therefore, if you give some vitamin K, it's going to help with the synthesis of those coagulation factor, and will reverse the effect of Warfarin. It's also teratogenic, so it's a no-no during pregnancy, as it can cause harm to the fetus. And if a woman is choosing to become pregnant and was on Warfarin, she has to discontinue the medication, and she has to be switched to another anticoagulant drug. So because of the risk of bleeding with Warfarin, the patient need to be monitored carefully, and the factors that is used to monitor the effect of Warfarin, so to see how the patient is able, the blood is able to coagulate, they measure what is called the INR, which is the international normalized ratio. So that's the most sensitive value for that particular medication to determine whether or not the patient is on the right dose of Warfarin. The INR ratio, the recommended INR ratio for a patient is 2 to 3. And so as indicated on my slide, you see that they have to be tested a few days or weekly. Once the dose is stable, they can start going, every 2 or 4 weeks. But at the beginning, you can have some patient going, every other day to test their INR ratio to make sure that the patient is either not at risk of bleeding or not at risk of clotting. So if the INR is within the range, sorry for the typo, then there is barely no chance of bleeding or getting a clot. Now, if the INR is above the range, so that means it's like more time for blood to clot, that means there is a higher risk of bleeding. And if the INR is below the range, that means there is a higher risk of clotting, because if the INR ratio is smaller, that means the blood is clotting faster. So in that case, the dosing has to be adjusted. If it's a higher risk of clotting, that means they need more drugs. And if it's a higher risk of bleeding, then that means they need less Warfarin. Also, this drug, has a lot of drug interaction. I kind of mentioned it during the principal lecture when we talk about binding to the plasma protein. This is a drug that is heavily bound to the protein. So any drug that will bind to the protein will have an interaction with Warfarin. And the thing is, if it takes the spot of Warfarin on those plasma protein, you're going to have more free Warfarin and a higher risk of bleeding. And other drug, it's not only the drug interaction, but it's also the food interaction. So any food that is rich in vitamin K, such as the green leafy vegetable, broccoli, Brussels sprouts, spinach, who contain a lot of vitamin K, they are going to increase the synthesis of those clotting factor, and therefore they are going to antagonize the effect of Warfarin. So patient who is a vegetarian and is on Warfarin needs to be aware. Of course, if their diet doesn't change, they will be titrated accordingly. But if it's someone who is changing all of a sudden their diet because they have to be careful and start eating more vegetable, this can really interfere with the dosing of their Warfarin and the effect of their Warfarin. Now you have also additive effects that are associated with bleeding, for example, with aspirin. So we're going to talk about aspirin with the anticoagulant. A patient can easily be on aspirin and warfarin, and so that means you have an increased risk of bleeding. And again, you know, like warfarin will be titrated appropriately when the patient goes to those Coumadin clinic and test for their INR ratio. Interaction with the CYP enzyme. Here we go again. So this is again something that you learn in your principal, and just to tell you how important those principal lecture were, because now you're going to apply them into those drugs that you are getting familiar with. Enzymatic inhibitor of a drug. So you remember, if you have a drug that inhibits the enzyme that degrade warfarin, that means warfarin is going to remain longer in the system. And so that means its anticoagulant effect is going to be higher, and the INR ratio is going to go up, because, you know, the blood is not going to clot as, you know, fast. So you have a higher risk of bleeding, and therefore the dosing of warfarin may need to be decreased. Example of drug that can interfere with our CYP inhibitors are the antifungal, the macrolide antibiotic, fluoroquinolone, cimetidine, calcium channel blockers. So these are factors to consider when a patient is started on warfarin, or vice versa, if it's already on warfarin and then is going to be added, let's say, with a drug for hypertension like a calcium channel blocker, which can interfere with the response of warfarin. Now you also have the inducer enzymatic, and so in that case, inducer means they are going to increase the metabolism of warfarin. So warfarin is going to remain, it's going to spend less time in the system. That means less anticoagulant effect. So that means the blood is going to be thicker, and in that case, the INR ratio is going to decrease. I mean, you know, because the warfarin effect are, you know, reduced, and the dosing of warfarin may need to be increased. Drug that can affect the metabolism of warfarin are the anti-epileptic agents such as carbamazepine and phenobarbital, and also patients who are smoking. Now, you know, as I said, warfarin was the only oral anticoagulant for a long time, but no, there are some like newer anticoagulant. Of course, when means newer means more expensive, so might not be covered by the insurance. And some patients, even though you know, there are newer and safer agents, they still prefer to remain on Coumadin once they are titrated right, and they are used to go to their Coumadin clinic to check on their INR ratio. They feel comfortable, and then also you can reverse the effect with vitamin K, so they feel safer, because the new oral anticoagulant, there is no antidote yet for those. So the first class of agent we are going to talk about are the factor 10A inhibitors, and these are direct factor 10A inhibitors. You remember when we talk about heparin, it's an indirect factor 10A inhibitor because it binds to prothrombin. Here it inhibits directly factor 10A. So, and you see I underline and also wrote in capital letter the X, or, you know, letter 10 in Roman numbering. Rivaroxaban, ApiXAban, it has the X because it's for factor 10. So that's how you can distinguish those agents that are factor 10 inhibitor versus the thrombin inhibitor. And so these are the most common factor 10 inhibitor, Rivaroxaban and ApiXAban. Adverse effect, again, bleeding. They are anticoagulant medication, so by now you should know that the major the major adverse effect is the risk of bleeding. As I said, there is no antidote, and because they are not as critical as warfarin, they don't need to have monitoring. We don't need to monitor their INR ratio or APTT like for heparin. So in this one, no monitoring of their efficacy is required, which is it's an advantage. But as I said, some people may be afraid of the risk of bleeding and may stick to their warfarin. Now, this medication, like any oral anticoagulant, especially those, with warfarin, is not as critical because warfarin has such a long half-life that you're not going to see this effect if the patient discontinue their warfarin prematurely. But with those new medication, if the patient forget one dose, skip one dose, you can have increased risk of thrombotic event because their half-life is shorter, and therefore if they skip a dose, you can have the reverse effect with it's the formation of a thrombus. So it's really important to educate the patient how important it is to be compliant with their medication and not skip a dose. And so that's why there is a black box warning. Now, clinical use, as you can see in one of their commercial here, it's used for the arthroplasty of the knee. So they would be given as post-operative thromboembolism prophylaxis because, again, blood can clot on those knee replacement and those prosthetic, and that's why patient has to take those anticoagulant medication as prophylaxis of thromboembolism. They are used for the treatment of DVT, AFib, and prophylaxis of systemic embolism. No, this site is for your information only, and the disclosure I have on this one is the only disclosure is just because my little Natasha is in this commercial, so you may have seen this commercial on TV for Eliquis. So hopefully you will remember that it's an oral anticoagulant and a factor 10. It's a factor 10 inhibitors. And if you want to play the commercial, just click on the link and you will see the commercial for Eliquis. But that's my disclosure just because Natasha is on the commercial. Now, another class of oral anticoagulant that is new are the direct thrombin inhibitors, and we saw one in the parenteral medication, or Xarelto, and here you see it dabigatran. Again, I put the TR in uppercase for you to pay attention. It's because it's a direct thrombin inhibitor. So as opposed of the previous class, which was the factor 10 inhibitor that has an X, so dabigatran. Adverse effect, again, bleeding, can also cause some GI distress, and then again there is the black box warning with the increased risk of thrombotic event when they discontinue prematurely. So very, very important to not skip a dose. Clinical use, they can be they are used for prophylaxis of DVT and pulmonary embolism, or they can be given following a parenteral therapy for patients who need a longer treatment. And they also used for the treatment of AFib because it can reduce the risk of stroke and systemic embolism in patients with AFib. So this is also this is the drug of choice in as anti-thrombotic therapy for patients with AFib at risk of stroke. And Dr. Chef will mention this drug when she does the lecture on atrial fibrillation. So this slide is a summary of the effect of the different anticoagulant, regardless of their route of administration. Here you can see the one that have a yellow box around, that's the heparin, so the unfractionated heparin and then the fractionated heparin. Here, so they are indirect factor 10 inhibitor, and they also interact with factor 12, factor 11, factor 9, and factor 2, and therefore prevent the formation of fibrin and then prevent the coagulation. The circle one are the factors, the coagulation factors that are vitamin K dependent, and so these are the factors that are going to be inhibited. The synthesis of those factors are inhibited by the action of warfarin. Then the triangle here are the direct thrombin inhibitors. So this was like Xarelto and the Bigatran. So these are direct thrombin inhibitors and block the conversion of fibrinogen into fibrin, so block the formation of those fibrin clot. And then lastly, you have the big X or 10. These are the factor 10A inhibitor, the direct factor 10A inhibitor, like ApiXAban, like Eliquis, and so this one act directly on factor 10. And so that's it for the oral anticoagulant, and thank you for listening, and I will see you in the next module.